And good afternoon, and welcome to Envision New Mexico today. Today we do have Dr. Lance Chilton is going to be presenting You Are the Key to HPV Cancer Prevention. We do have a few slides that we need to run through before we get started in order to provide our CMEs for today. And as a reminder, today you won't be on audio or video as we do have a number of participants, which is fantastic. So what we'll be doing is taking any questions that you might have through our chat box. So that should have popped up for you at this point, and I'll send out another message as soon as I hand it over to Dr. Chilton. So it will start blinking at you. And so feel free to type in questions at any point, and what we'll be doing is saving those questions for the end of the presentation. If you do wish to receive a CME or CEU or attendance certificate, we will need to know your name, and it'd be nice to know where you're from, where you're working. So go ahead and feel free to do that through the chat box at any point starting now, and we'll get all of that exported and jotted down for your participation towards the end of the session. We will have another opportunity to do that at the end of the session as well. Our disclosure and accreditation statements are on screen now. For some of our other initiatives, we do offer case consultations. Those are reimbursable by Molina Healthcare and Blue Cross Blue Shield New Mexico. So if you are interested in that, we will be starting our adolescent health initiative sessions again here in the fall, in September it looks like. So, and we do have case consultations as a part of that. So keep an eye out for that. If you have any questions, feel free to email me or Michelle Weidner. And our information is at the end of this slide set, which is downloadable, by the way, from our website calendar at envision.unm.edu. And as I see many people are already, please go ahead and type into that chat box who you are and where you're from. And as you've already registered, we have all of your demographic information that we would need otherwise. So just let us know who you are and we'll get you your credits. And at this point, I would like to go ahead and introduce and hand it over to Dr. Lance Chilton, who will be presenting on You Are the Key to HPV Cancer Prevention.
Thanks very much, Kevin. I'm really glad to be here, and welcome to all of you who are on the other end of this transmission. I wish I could see all of you, but I'm glad to hear there are a lot of you. Thank you for attending, and I'll get started because I have lots of slides and lots of information. And I want to thank the Centers for Disease Control for providing the slides, most of them. And also a number of people, Vicki Nakagawa and Beth Pinkerton at the Department of Health here in New Mexico, Patrick Mais and Amy Gundlach from the Gynecologic Cancer Awareness Group, and Anna Pantler and Maggie June from the New Mexico Immunization Coalition. So thanks to all of them. As is usual, I want to give a disclosure that in the past I've spoken on behalf of Merck Vaccines, but not at all recently, and I have no other conflicts. The objectives for this talk are to describe why HPV vaccination is really important for cancer prevention. That's the main issue. I want to identify what the new recommendations are for giving the vaccine to kids, describe that to you, describe them as being particularly important between 11 and 12, but also for older children and young adults, and to help you feel efficacious in giving the recommendations that we'll be talking about. And as you'll see shortly, we'll do a little bit of role playing, Dr. Bennett and I, about how to deliver this information. And she'll be nearly perfect, but I'll always find something to edit, I'm sure. So let's go on to that role play. Dr. Bennett, I've brought my daughter Linda here, and thank you for examining her. Can we go now?
Well, today is a really great day for us to talk about the vaccines that your child needs for update. So there are several that we want to talk about today, and in the same way that we would do all our other vaccinations. So we would have her diphtheria today, and her meningococcal vaccination, and her HPV.
Okay. Is that what you say to all 11-year-olds, or is it specifically because it's something Linda told you while I was out of the room?
No, this is just our standard immunization schedule. It's what the American Academy of Pediatrics recommends for all kids of this age. We want to make sure that kids stay healthy.
Well, I understand that the diphtheria and tetanus and whooping cough vaccine is required for school, so obviously we have to get that one. And I don't like the idea of my daughter getting meningitis, so we'll get the meningococcal vaccine. But what's this about HPV? Why is that so important?
That particular vaccine is a prevention vaccine for cancer. Many of us are infected with HPV, and it's one of these things that we want to make sure that when we're exposed, that our body can fight off an infection that might lead to cancer.
But why so early? Why? She's only 11. Why should we give it to her now?
Our bodies are really strong at this age, and that's the best time to give vaccines for our body to work on its immunology and its response to infection. So the longer her body has to create a protection for that virus, the better off we are.
But it's a new vaccine. Has it been tested adequately? Is it safe?
It's been around since 2006, recommendations for girls, and there are a lot of safety tests, and it's very much similar to the other vaccines in terms of any kind of potential side effects you may have heard of. We consider it a very safe vaccine. I wouldn't recommend it to you if I didn't think it was the best thing for your child at this time, along with her other preventive vaccines.
Well, thank you for explaining that. I guess my last question is, would you give it to your kids? I know you have some teenagers yourself.
Yes, I have an 18-year-old daughter and a 15-year-old son, and both of them were vaccinated. They started their vaccine series at this time, and that's been completed.
And they did well, I think.
They did well. You know, it's always when you have to get poked for anything. You know, you come to your clinic appointment, and you thought you were just going to get your sports physical, and lo and behold, it's time for a shot. So that was the only discussion we had. So it cost me a little bit in ice cream cones afterwards.
That's a low cost compared to the cost of cancer, isn't it?
Yes, very low cost.
Well, I think I'll have Linda immunize. Dr. Bennett, you've convinced me. Thank you very much for being so open with me.
Welcome. I'm glad you asked your questions.
So, Dr. Bennett did an excellent job and we'll talk a little bit more about the components of what she talked about. I was Mrs. Aurelia Sanchez, and my daughter Linda will get her immunizations today. And I should say, parenthetically, that I, as an older adult, have 5 grandchildren, all of them immunized against HPV, because I think it is so important. So let's go on and talk a little bit about HPV, the infection, the disease, and the vaccine, of course. So first of all, let's talk about promoting HPV vaccine as cancer prevention, not as license for having sex, not as a sexually transmitted disease, which it is, though, but as cancer prevention. And I like these 2 CDC slogans here, but the one I like best, which was last year's one, was, if there were a vaccine against cancer, wouldn't you want it for your kids? Well, I wanted it for my grandkids, and they got it. My daughters were too old by the time the vaccine came out. So let's talk about the types of HPV. You'll see on the right side of this slide that there are about 80 different types of HPV, human papillomavirus, that cause hand and foot warts. Okay, we're not going to talk about those. It'd be nice to be able to prevent those too, but we don't have a vaccine that does that. The other blue one here in the middle of the slide is the 2 types of HPV that cause genital warts, type 6 and 11, and they are included in the vaccine. That's a nice sort of side effect of getting the vaccine, which is primarily, for the left side of the slide, for prevention of a variety of cancers that we'll be talking about, and changes in the cervix in young women, which I think are also important. So most, as Dr. Bennett said when I was talking with her, most males and females will be infected at some point with some type of mucosal HPV. Currently, about a quarter of the whole U.S. population is infected. And that indicates that a lot of those people have been infected recently, since most people who get the virus don't know about it and eventually lose the virus. Now that's most of them, but it's not all of them. And that's what we're talking about, the ones who don't lose the virus, where the virus stays on for a while and causes all kinds of havoc. This is the number of cases of cancer that are thought to be caused by HPV per year in the United States over the 4 years period between 2009 and 2013. You can see here that the most common types of cancer caused by it are cervical cancer and oropharyngeal cancer. The former, obviously, only in women. Oropharyngeal cancer is much more common in men. And then there are a number of other types, which add up to still another 10,000 cases of cancer per year in the United States. I like this slide because it summarizes a lot of what was on the previous slide and on a number of other slides. That first of all, there are cancer-causing HPV types in all of the vaccines that we've ever had. There are 5 types that are included in the more recent HPV vaccine. There are a few types of HPV that cause cancer and are not included in the vaccine, unfortunately, at this point. And then there are a few cancers of all these types that are caused by something else, such as smoking, for example, with oropharyngeal cancer, that we can't prevent with a vaccine. But you can see that if you add up the dark blue and the light blue types, the ones that can be prevented by the vaccine that we have, that takes care of most of the cancers of these various types. Looking at it by race and ethnic group, you can see for the United States that females have a slight preponderance. They're more commonly involved with cancer caused by HPV than males, although that is changing. And that there's somewhat less total cancer in Native Americans than there are in other ethnic groups, except for Asian Americans, where it's lowest still. The rates for Hispanic and non-Hispanic white people is about the same. There is some difference in cervical cancer rates across the United States. In New Mexico, it's interesting that there isn't much of a difference between the rates in whites, Hispanics, and American Indians. Unfortunately, the risk of death from cervical cancer in New Mexico is higher in Hispanics and American Indians. Similarly, with oropharyngeal cancer, the rates are somewhat lower in Native Americans and in Asians, a little bit lower in Hispanics than they are in white non-Hispanic Mexicans, or sorry, Americans. The rate of death from cervical cancer has been falling gradually over the last 50 years, and that's a very welcome statistic. But as you can see here at the right side of this graph, the rate of fall has dropped off, so there's pretty much a flattening of the curve recently. Now we can do better, and we should do better. Hopefully we'll start doing better when the effect of the HPV vaccine is felt, about 10 or 20 years after the dose is given. Cervical cancer and precancer are obviously female diseases, and these statistics have to do with US females. The number of cases of cancer around the world is about 500,000 per year, and the number of cases of death due to cervical cancer is about 250,000 per year across the world. But this slide talks about US females and doesn't talk about the incidence of disease, of cancer, or of death from cancer, but rather cervical dysplasia. And as a male, I probably don't know as well as the females in the audience the heartache and the misery that is caused by even low-grade cervical dysplasia and the follow-up for that. Low-grade and high-grade cervical dysplasia often require surgical treatment, and the surgical treatment is painful and problematic from a number of standpoints. So I don't want you to think that we're just preventing cancer, we're preventing precancer as well. This little girl is maybe typical of adolescents who think it's not going to happen to me. It looks like she's doubtful about it. Well, of course, teenagers don't think that anything's going to happen to them. We need to take the issue out of their hands. So let's talk a little bit about the vaccine that is in our hands. In the past, we've had 3 vaccines: the bivalent vaccine, or Cervarix, the quadrivalent vaccine, which is Gardasil, and the 9-valent vaccine, which is Gardasil 9. But as of last year, only the 9-valent vaccine, or Gardasil 9, has been available. And so we'll be talking mostly about that. And as you can see here, the 9-valent vaccine prevents the 2 types of HPV that cause genital warts, the 2 types that were in both of the previous vaccines that cause the majority of cases of cervical cancer and other cancers in the body. And then they also prevent 10% or more of the remaining types that had not been in previous vaccines. So it's definitely a vaccine that prevents a great deal of the problems that we have. The recommendation for this vaccine, as given by the CDC and all the agencies that recommend vaccines, is that the vaccine be given preferentially at 11 to 12 years of age. For children who we think aren't going to be able to come back, maybe they're going to Africa on a mission, let's say, or something like that, or they may be losing their health insurance, we can give the vaccine as early as age 9. And it's just as efficacious at that age. We can also give it to those who haven't gotten the vaccine at 11 or 12, and we should be giving it to anybody who hasn't had the vaccine before, up to age 26 in girls and up to age 21 in boys. And there's some exceptions to that, which I can address with regard to the questions if you like. Whoop, what did I do? Okay, so again, 11 or 12 years. The new recommendations as of last year are that if you start the vaccine when it should be given, it can be given as 2 doses, and the second dose needs to be given somewhere more than 6 months after the first dose. The recommendation is 6 to 12 months after the first dose, but in actual fact, you can give it at any time after 6 months after the first dose, preferentially earlier. So the schedule for those who begin the vaccine before 15 years of age, before their 15th birthday, 14 years and 364 days is fine, is 2 doses of the vaccine separated by 6 to 12 months. For those who start after they've had their 15th birthday, it's 3 doses. So that's one good selling point for giving it before that time. 3 doses, the first, and then the second of 1 to 2 months later, and the third at least 6 months after the first dose. We can talk more about the minimum interval and how that affects those who've already received the vaccine in a little bit. So this is a new slide from the CDC showing the balance between risks and side effects of the vaccine. And the initial slide that I used for this before showed a balance between the two. But you can see that the scales are tipped greatly towards the benefit side and much less toward the side effect side. So let's talk about side effects of HPV vaccine. First of all, we'll talk a little bit about the safety system for vaccines in general, some of you have probably reported side effects to the vaccine adverse event reporting system, or VAERS. This is a useful way of getting some information on a passive basis. It doesn't give us either good numerator or denominator data. And so when a signal is received that something might be amiss with a vaccine, it is given to the other three systems, and others really, that are activated based on VAERS reports. So the Vaccine Safety Data Link is perhaps the most important of them. It consists of 9 integrated healthcare systems with excellent medical records, so they can look at possible side effects and what's happened following vaccines and what's happened to the same group of patients who haven't gotten vaccines recently. So there are over 10 years of data on safety of HPV vaccine. There are lots of things that have been mentioned as possible side effects, and if you go online, you'll find a lot of them. But the only things that have been found are very rare allergic reactions and brief fainting spells. And the Institute of Medicine has verified that these are the only things that are likely to be related to HPV. Because of the fainting spells, all adolescent vaccines should, and probably earlier as well, should be given, and then patients should be allowed to sit or lie down for a while afterwards. It's not pleasant to have somebody lying on your exam room floor after they've been given a vaccine. But there are ongoing efforts to identify any problems with HPV vaccine, and these ongoing efforts based on tens of millions of doses of HPV vaccine have shown universally that the vaccine is safe and, as we'll talk about later, effective. Well, this is later, I guess. So we'll talk about the outcomes of the vaccine. First of all, early outcomes have been shown have shown the vaccine to be very effective, and I'll come back to that shortly. Early precancers have also been looked at, and we'll talk about that. What we can't talk about so much yet is the late outcomes, since cancers caused by HPV usually don't become evident until 10 to 20 years or more after the infection, and we haven't gotten that far with the vaccine yet. So looking at data from a number of countries, we've been able to show that quick things like genital warts have been markedly decreased with all of the vaccine, with the quadrivalent and the current vaccine in at least 6 countries. So that's really good information. Genital warts are not serious, but they sure are unpleasant, and adolescents don't like them much. The prevalence of infection has been markedly decreased in at least 5 countries now. And the US data are remarkable. I have left out a slide that shows those data, showing that there's a more than 50% drop in the prevalence of HPV infection in teenagers, despite the fact that our immunization rates in the United States aren't as good as we'd like. And then there is data that show that in 5 different countries, again, there are decreases in the early signs of precancer. Wonderful information. We'll talk a little bit more about that in the slides to come. So in 9 high-income countries where they've done better than we have in giving the vaccine, the prevalence of infection with the 2 types of HPV that have been in all 3 vaccines has been decreased by more than 2/3, and that the incidence of warts, which are protected by the vaccine, by both of the quadrivalent and 9-valent vaccines, have been decreased by 60%. There is evidence of herd effects. So even if you haven't been immunized, your chance of being infected by somebody who has been immunized have been decreased, and that's very welcome information. It's also welcome that some of the vaccine types, some of the types that are not in the vaccine, seem to be protected against as well by the vaccines that we've been given. Well, this is something you don't want to see over lunch, so I'll skip past it, but it may be that genital warts are an even better selling point for adolescents, because while they may not believe that they're ever going to get cancer, they certainly don't want to have those things that I just showed on that last slide. Despite that, despite all of what I've said about the effectiveness and the safety of the vaccine, we're still not doing very well in the US on coverage against HPV. This slide is kind of complicated, but shows that the one that's required for school here in New Mexico and across most of the country, the Tdap vaccine, is fairly well accepted, not surprisingly enough. And the meningococcal vaccine is close behind. We're still far behind. We're in the neighborhood of completing the series in about 40% of girls and about 20% of boys. So we have a long way to go before we're protecting the whole population against HPV. We could do better. And one of the ways we could do better is to eliminate missed opportunities. As Dr. Bennett said, with regard to something that about her own children, we could be giving this immunization at visits other than those that are scheduled for vaccines. So if somebody comes in for a sports physical or a cold or something else where there isn't an absolute contraindication to vaccination, we could be getting most of the girls and also most of the boys sometime before they're getting their first and second vaccines. Of course, it's only 2 now for most of them, and that's a good thing. Well, let's review Dr. Bennett's performance, framing the conversation. She did a great job, and one of the things she did was to start off by talking about all of the vaccines that were needed. This information on this slide indicates that we as clinicians, when we've been subjected to focus groups, are much less sure about parents valuing HPV vaccine than we are about other vaccines, and then the parents themselves actually are. So in other words, most parents, 93% of parents believe that HPV vaccine is important, but only 52% of clinicians agree that parents value it highly. So we have to catch up with our parents. Among the reasons given in focus groups for not starting the vaccine for children are these: that their child isn't sexually active yet, that the recommendation hasn't been given to them, that there are safety concerns about the vaccine, that it's not needed or necessary, and that they just don't know enough about the vaccine or about HPV. And we can have effect on every one of those. I circled the one about not recommended, but they're all important reasons that we can affect. So we need to listen to the perceived and real concerns of parents about the vaccine and about the disease. And Dr. Bennett did that very well. So first of all, we need to give an effective recommendation to our patients when they come in for their 11 or 12-year-old visit. So we need to do that in a way that it is effective to convince them to give all of the vaccines that the children need at that age. So what is an effective recommendation for HPV vaccination? Well, CDC says, and I like this, that it should be given in the same way and on the same day that the recommendations for the other vaccines needed at that age are given. We'll keep on going on this subject for a little bit. So the same way, we need to recommend HPV vaccination right alongside the Tdap vaccine and the meningococcal vaccine, and not apologize for including this vaccine. We need to recommend that it be given today while you're here in the office, and at the same time as Tdap and meningococcal vaccine. And there's no reason to wait. There's no interaction among these vaccines. So what Dr. Bennett essentially said was your preteen needs 3 vaccines today to protect against meningitis, HPV cancers, and diphtheria. She said pertussis and tetanus are all contained in that Tdap vaccine. I don't usually say pertussis because I think parents understand whooping cough better, but that's a sidelight. So here's a brief option. Now that Sophia is 11, she's due for 3 vaccines today that will help prevent meningitis, cancers caused by HPV, and whooping cough. We'll give those vaccines at the end of the visit. A slightly longer version is this one. Now that Sophia is 11, she's due today for 3 important vaccines. They're to prevent an infection that can cause meningitis, which is rare but potentially deadly, to prevent a very common infection, human papillomavirus, that can cause several different kinds of cancer. And the third is the tetanus, pertussis, and diphtheria vaccine, which not only prevents whooping cough in your child, but also protects children too young to be vaccinated. So we'll give those vaccines at the end of the visit. Do you have any questions for me? And I think Dr. Bennett's answer was somewhere in between the brief and the longer version, but it was very effective. Some parents need reassurance, and obviously I wasn't one of those parents who just accepted what she said. But most of the parents in my practice did do that, and most will. So stop there. There's no need to apologize for giving these vaccines. Just keep doing it, just as you would with the vaccines that you give at a year of age. Some parents may be interested in vaccinating, but they still have questions. We need to interpret their question as a chance to reassure them and to continue their trust in you. And try to find out what their main concern or concerns are, just as Dr. Bennett did. So here's some of the concerns. Why does my child need the HPV vaccine? I think we've both Dr. Bennett and I have done that it's important because it prevents cancer. And that's the message. This is a cancer prevention vaccine. That's why we're recommending that we start the HPV vaccine today. So what cancers are caused by HPV infection? I'll skip over that because we've already talked about that at some length. Is my child really at risk for HPV? Well, the answer is definitely yes. Some 70% of sexually active adults have been infected or are infected with HPV, and about a quarter of the entire population is infected. So it's a very common and widespread virus, and we can prevent the cancers caused by those by starting the HPV vaccine today. Why at 11 or 12 years of age? Well, there are a number of reasons. Some of them are on this slide, and I'll give you a couple more. Well, I love these 2 slides that I'm going to show now. These are new CDC slides. So when should the bike helmet go on? Before the child gets on a bike, when they're riding their bike in the street, or when they see the car heading directly at them? Well, obviously you'd say before they get on the bike, right? When do we put our seatbelts on? Before turning on the car, when leaving the driveway, or after a near accident? Well, probably you'd all say before turning on the car. So the same is true about the HPV. We want to prevent the disease by giving the vaccine before a child is exposed to the virus. And that will usually be best done at age 11 or 12. So we'll give the first vaccine today and then have you come back in 6 months or a little more for the second shot. Here's a question that I didn't ask Dr. Bennett, but one that I think is behind a lot of the reticence of parents about giving the vaccine to their kids. Maybe this is a green light to have sex. Well, it isn't. According to numerous studies now in 5 different countries, there is no difference in sexual activity in those who've been given the vaccine compared with those who have not. So you don't need to worry about that, and it's important perhaps to bring this up, even if the parent has kept this concern to you, away from you, but has it in the back of their mind. How long can we wait and still give just 2 doses? Well, the answer is that CDC recommends that all children under the age of 15 get only 2 doses of the vaccine. However, there's no reason to wait. And one of the other reasons that I should have mentioned a moment ago for giving it at age 11 or 12 is that 11 and 12-year-olds are a little bit more likely to accept the recommendations of their parents than 15-year-olds are. We tend to withdraw from our parents' advice the older we get. So that's another reason to give it early. So the doctor should say, I'd feel best if we started the vaccines today to get your child protected as soon as possible. And the other reason is that 11 or 12-year-olds have a better immune response to the vaccine than those who are older, particularly young adults who don't respond to the vaccine as well. So here's the question that I got the most commonly, that there are concerns about safety of the vaccine, and that there are lots of complaints online about supposed unsafe parts of the vaccine, or diseases or problems that can be caused by it. And we've already talked about that to a large extent. How do we know that it's safe? So it helps to know some of the information on my slides about the safety mechanisms in place for all vaccines in the country. It's really a very robust system, and one that I feel very confident in being able to recommend vaccines that have gone through that process and continue to go through that process. But if the answer is that you're usually in support of vaccines, but you're worrying about HPV, we can talk about some of the information about those tens of millions of doses of HPV vaccine that have been given around the world, and the fact that there haven't been any safety signals other than that very rare allergic reaction and the fainting. So I believe that the data show, and that all of the relevant recommending bodies show and believe, that HPV vaccine is very safe. And you can leave it at that. And if that isn't enough for some patients, you can refer them to the CDC website, to the American Academy of Pediatrics website, the American Academy of Family Practice website, and they all give the data on which this very safe notion is based. So you can go on to say that sometimes kids faint, sometimes there's some pain or swelling around the vaccine. And between you and me, but you don't need to say it to the patient, there seems to be perhaps a little bit more pain where the shot is given, the HPV shot is given, than with other vaccines. So then the next question that may be behind some of the parents' minds is, could HPV vaccine cause my child to have problems with, and here the CDC has left out, with having children later? And the answer is really the opposite. There are no data suggesting that HPV vaccine will affect future fertility. I haven't mentioned it yet, but I should mention that this is not a live vaccine, so there is no way that this vaccine can cause HPV infection or cancer itself. On the other hand, women who do develop precancer or cervical cancer may be subjected to surgical procedures that in turn may limit their ability to have children. So if we can prevent those precancers and cancers by giving the vaccine, we may be able to increase the likelihood of your daughter's ability to bear children later. Something certainly to think about. So again, the safety of HPV vaccine has been well shown. And here's a whole list of things that aren't caused by HPV vaccine but have been mentioned on the internet. The HPV vaccine doesn't cause anything except protection. How do you know if the vaccine works? And again, we've talked about this already, that it works very well in preventing genital warts and in cervical precancers, and in another 10 or 20 years, we'll be able to show that it prevents cancer of all these types. That's terribly important. Why do boys need HPV vaccine? They don't get cervical cancer, of course. They don't get vulvar or vaginal cancer, but they do get oropharyngeal cancer at a rate about 4 times as high as women. And oropharyngeal cancer is on the increase, while cervical cancer is decreasing. So there also are cancers of the penis and anus in men. These are important as well, but much less numerous. The other thing, of course, is that men are the primary vehicle for women getting the virus that can cause cervical and vaginal and vulvar cancer. So preventing the infection of males also protects females. So if the patient says, we only want the vaccines needed for school, what's your response? I should have said this to Dr. Bennett, that I only want the Tdap vaccine since that's the only one that the schools require in New Mexico. And the answer, the answer is that all of us, the CDC, the pediatricians, the adolescent physicians, the family medicine doctors, the cancer awareness groups, all recommend all of these vaccines, and in particular HPV vaccines. So while the school entry requirements haven't caught up and probably aren't going to in New Mexico for a while, it is very important that the vaccines be recommended, all 3 of them. So the final question that I asked Dr. Bennett is, would you or have you gotten HPV vaccine for your kids? And the answer, I hope, for all of you is that yes, I've given HPV vaccine to my child, or in my case, my 5 grandchildren have all received the vaccine, and I believe strongly in the importance of this preventive measure in preventing cancers. Again, if there were a vaccine against cancer, wouldn't you want it for your child? Well, my answer is I definitely would. Here's a question that Dr. Bennett asked me actually before we started this webinar, that there's a new HPV vaccine that works better. Should I be getting that for my child who already was vaccinated? And she was asking me this question because her daughter got the previously existing vaccine, which had 4 types in it rather than the 9 types that are available now. And the answer is that CDC does not recommend that there be revaccination of those, but this is something that you can talk about with your patients and form your own opinion on. What am I doing here? So the current vaccine that we have is the best that's available anywhere in the world. There is no recommendation for additional vaccines for someone who's already received the HPV vaccine series. But again, talk about it with your patients. All of the HPV vaccines protect against type 16 and 18 HPV, which are the ones that cause the majority of the cancers. When do we need to come back? Okay, so this is the patient asking you, when do we need to come back for the next dose? And the answer is, since your child is younger than 15, she'll need the second shot in 6 months to a year. Make the appointment now. And for you, in your office, make a point of reminding the patient in 6 months that they need to come in for that second dose. So if your child's already had 2 doses, but is less than 15 years old, why might she or he need a 3rd dose? And the answer is that it appears as if it takes at least 6 months between the vaccines, or CDC hedges and says 5 months, between the first and the second dose for there to be effective protection. So if the first 2 were received less than 5 months apart, then a 3rd dose should be given. Other than that, though, if you're under 15 and you've received 2 doses, that's enough. And will your child be protected with just 2 doses? The answer is yes. In fact, the protection for young women under 15 years of age is better with 2 doses than it is with 3 doses for older adolescents and adults better. If the parent says no today, then you can do these other actions: ask, acknowledge, and advise. And I would summarize these by saying, I would tell parents, I'm going to bug you until you agree to give the vaccine. So if the parent declines, the declination is not final. We're going to talk about it each time you come in. You can say that in a nicer way than I just said it. Because waiting the vaccine is the risky choice. Some physicians will say, please sign that you don't want the vaccine now. We didn't do that in my practice, but it's an interesting idea. Getting your office behind you is important. I've eliminated a few slides here for time reasons, but making sure that everybody in the office is giving the same message and having the mission that everybody needs this vaccine and communicating pretty much in the same way between the front desk and the end of the visit is really important. There's a lot of information available, and I'll show you one place where you can get it. But talking about it within your office and having office procedures to maximize the use of this vaccine is really important. Making sure that there isn't somebody in your office who's sabotaging the effort and has read too much on the other side is important. Here's some of the information that's available on the CDC's website. There's information both for parents and patients and also for professionals. It's a great deal of information. Some of it is really good. The one I like the best actually is one that says short ways to intervene with parents, because I think all of us are time limited in what we can say. So we want to say what we need to say quickly and effectively. Here's some of the information that's available. You'll see two posters there in the lower right side, which are available through CDC free. And they're also available through the New Mexico Immunization Coalition. So if you want to write down Maggie June's number, it's 272-3032, 505-272-3032. She'll send you some. She has them. And they both say, if there were a vaccine against cancer, wouldn't you get it for your kids? A great message. So it's up to you. You're the key. I can talk about it, but you can talk about it with patients, and I hope you will. And I hope now you'll send me your questions, and I can answer those questions. And thanks for your attention.
So, Dr. Shelton, you have one question up here. Does insurance pay for the HPV for patients over the age of 18?
That's a very good question. Thank you for it. That presupposes another question. Let me answer the other question first. For those who are before their 19th birthday, they can get the vaccine free at any office because of New Mexico's Fine Vaccine Purchase Act. So that's the answer to the second question. But the first question is that according to the Affordable Care Act, all insurance plans must cover CDC recommended vaccines. So the answer is that if you have any form of insurance, it will cover the vaccine.
And then you have a follow-up question here. Can you go back to the last slide about getting the preteen vaccine newsletter? So that's good. So I think if that's potentially what they wanted there. And then a follow-up question again, up to 24 years. So I'm not sure there's a question mark. In other words, is the vaccine we talked about being paid for to 18, is that true under the ACA for kids who are still covered by their parents' insurance?
Yes, it is. Good question. It is covered by any such insurance up to age 26 is when ACA says you can be on your parents' insurance. And because 26 happens to be the same age that the CDC recommendation is in force, the vaccines will be covered for all such children up to age 26.
So we don't have another question there, but I'm going to ask one. In terms of the follow-up for girls and boys who got the vaccine at 11, 12 and got the 4-valent vaccine, do they only have to have 2 shots with the 9-valent, or do they have to have 3 again because they got 3 in their previous vaccination schedule?
There isn't guidance on this. My guess is that they would only need 1 9-valent vaccine.
Oh.
But again,
So
CDC
there's
is
no
not
guidance on that if
No.
a parent were to decide to come back and vaccinate again.
Right. So we have another participant here in the room. Maya, did this bring up any questions for you?
Not really. I guess I was just curious. So if the providers wanted to explain to the patient what they were doing, is there any way they could explain why it hurts so much? Why that vaccine will hurt? It will hurt more than maybe some of their previous ones. Is there a reason behind that?
There probably is, but I don't think it's known.
Okay.
And in fact, the newer vaccine seems to possibly be even more painful than the 4-valent vaccine, probably because there's more than twice as much of the active substance in the vaccine. But I don't know, and it's pretty hard to judge pain anyway.
Right, yeah. But I know when I had it, it was hard to get myself to go back for the next ones because it did hurt so much.
Yeah. And we just have to rely on our persuasive abilities as doctors and as parents, and hopefully to note the difference in pain level between this vaccine that hurts for a few minutes and cancer which hurts forever.
Right.
Any other questions, or Kevin, any questions that came up in your mind?
We just got one. As a side note, we have always made patients wait 15 minutes after administration, as we have had 3 people faint, boys and girls. So a comment from John Helm.
Well, thank you for the comment, and that you're following the suggestions that CDC and the American Academy of Pediatrics and American Academy of Family Practice all make, that even though it's a hassle to keep people around, and it ties up space in the office, it's a good idea. There have been extremely rare instances of people falling and actually hurting themselves when they've fainted.
I did want to mention, and thank you, Dr. Chilton, and any other questions, we do have a few more minutes until our hour is up. We do have a post-session survey. I'll post that again here in just a moment, and we'll email that out as well. If you could just take a couple of minutes to fill that out, it helps us improve our programs here with telehealth, technical and otherwise. So we appreciate your taking a couple minutes to do that.
Then I was just wondering too, it seems we have a lot of participants, but I haven't seen very many chat responses to who people are and where they're practicing. So I just want to make sure if you want CME or CEUs for this particular session today, we really need to know that you were here. So go ahead and send those your names in the chat box, and Kevin can leave the chat box up for a few minutes afterwards if it looks like we're going to have a flood of responses. If you don't want CMEs and CEUs, that's fine. You don't have to take them, but they're free to you, so it's a great opportunity.
Well, thanks to Envision for hosting this. I've sort of been on a mission the last few years to get HPV accepted better in New Mexico, and you're the key. I'm not.
We just have one more question, Dr. Chilton, if you have a moment. Why is the age limit for men 21?
Well, this is a cost consideration. It's a good question. The cost effectiveness discussion is such that for males over age 21, it's considerably more expensive per quality adjusted life year than it is for females. Now that's sort of an opaque statement, and I'll try and explain that a little better. For women up to age 26, it's clear that the cost effectiveness is high compared to other vaccines. For males over age 21, unless they happen to be males who have sex with males, and there are a couple of other categories, so those who are immune suppressed, the calculation is that not as much is saved. There's not as much cancer in males. But stay tuned, that may change because the incidence of oropharyngeal cancer, particularly in males, is going up, while the incidence of cervical cancer is going down. So this may change in the future. I hope that answers your question. Anything else? Well, again, thanks for being with us. Go out there and immunize.
And thank you all again. And as Kirsten Bennett just mentioned, I'll leave the chat box in the room open here for a few minutes afterwards.
Yeah.
One more question.
One more question squeaked in at the wire here. Are any of the adverse effects of Gardasil enhanced if there are other things like diabetes, etc.?
That's a good question. Is there anything that makes that makes the side effects more common? And I would say to that the answer is no. Diabetes is not a reason not to immunize. Immune suppression is not a reason not to immunize. Remember, this is not a live vaccine, and so it cannot cause disease in anybody, whether you have a good immune system or not. Although diabetics do have some problems with infections, they do not have a problem with responding to this vaccine. I suppose if you were more prone to faint, if you were one of those who fainted when you had your blood drawn, like my daughter did numerous times, you might be more likely to faint. So you'd certainly want that person to sit down. But that's the only caveat to my answering no.
All right. Well, thanks so much, Dr. Chilton. It was great to have the New Mexico perspective. And I think Kevin said this early in the session. If you have questions that you think up later, you can send them to either Kevin or Michelle. Their contact information is on the last slide, and we can get those off to Dr. Chilton.
And I'll answer them.
All right, we'll go ahead and stop our recording and sign off now. Again, we'll leave our chat box open here for a few more minutes in case you haven't signed in. Thank you again, and thank you, Dr. Chilton.
Thank you.